Hi, everyone. I'd like to welcome you to our webinar tonight on navigating the new Focused Practice Designation exam in adult and complex thyroid and parathyroid surgery. We put together a great panel. My co-moderator, Dr. Joe Sharp, will be moderating and will be monitoring the chat for questions. So if you have questions, please put them in the chat. And then we have a great panel of speakers. Unfortunately, Dr. Ben James will not be joining us, but Dr. Whitney Liddy, Dr. Salem Noraldine, Dr. Carolyn Sieb, and Dr. Meredith Sorensen. Just to get started, we want to go through just a couple of disclosures, none that are actually related to this presentation at all. Our objectives are really to just go through what the purpose and value of the exam are, to identify the eligibility criteria, let people know about the exam content, discuss the implications a little bit for patients, and help each and every one of you develop a plan for taking the exam if that's what you choose to do. The session is divided into just this welcome introduction, the background and rationale. We'll go through eligibility criteria, the format in terms of timing, logistics, and content, and some study strategies, and then we'll open things up for the panel. So again, please put your questions in the chat. I'm going to have Joe go through some of the terminology for you, and then we'll get going.
Hi, good evening, everyone. So in terms of the terminology, the focused practice designation is probably familiar to some of you, but not all. You certainly have your primary certification, then subspecialty certification, and then it goes into focused practice designation. So showing additional expertise in a particular area of primary specialty is there in terms of the terminology for this. So it doesn't necessarily take away your primary board certification. It's not supplanting that. The updated numbers from the most recent group. So this was the first group that took it in the spring in April. There were 217 diplomats. It was pretty even between both boards, between ABS and ABOHNS, 109, 108. The pathway was also pretty similar. So 80% went through the practice pathway, 20% through the training pathway. And the pass rate was quite high at 97% for this first group that went through.
All right, back to the rationale. Next slide. So in 2019, representatives from several boards, including the American Board of Surgery, the American Board of Otolaryngology Head and Neck Surgery, American Association of Endocrine Surgery, and the American Head and Neck Society first came together to discuss the creation of a focused practice designation for thyroid and parathyroid surgery. This focused practice designation was approved in the spring of 2022. By the fall of 2022, a steering committee, including 5 ABS members and 5 ABOHNS members, was created. Next slide. From here, the Focused Practice Designation Exam Committee was then formed, which was made up of 20 members, again, 50-50, ABS and ABOHNS. And they were really tasked with actually creating the exam, which you'll hear about in a little more detail in a few minutes. The first written exam was given in April of this past year, with the first cohort of surgeons earning the Focused Practice Designation identified in May. Next slide. The rationale behind the Focused Practice Designation was born out of a perceived need to be able to better identify surgeons with an expertise in thyroid and parathyroid surgery. We know the landscape's confusing. Thyroid and parathyroid surgery is performed by surgeons in 2 different surgical specialties with a variety of training backgrounds, and really no clear board certification to identify or highlight expertise in the area. This is not only potentially confusing or challenging for our primary care physicians or other referring physicians, but it can be particularly challenging for the patients themselves. Next slide. And my apologies here, Ben couldn't make it, so these are his original slides, but I think the point here is clear, which is when you have a patient with a new diagnosis of thyroid cancer, perhaps even with more advanced thyroid cancer, where do they go? How do they know where the experts are? Next slide. And so a need really was identified to do a better job of pointing out these experts to both the patients themselves, next slide, but also to referring physicians. Next slide. All right, so the exam itself is designed for either ABS or ABOHNS certified physicians who are actively engaged in high volume and complex thyroid and parathyroid surgery. It's really not for surgeons who only perform a few of these cases per year. Next slide. There are two separate tracks to obtain the Focused Practice Designation. The practice track is for ABOHNS and ABS diplomates who either never completed an accredited fellowship or are greater than 5 years out from fellowship. And this track involves documentation of at least 120 qualifying cases over 3 years, with at least 24 of these designated as complex cases, the details of which will be reviewed in a little bit. And then the other pathway is the training track for those surgeons who have completed an AAES, ACS, or AHNS accredited fellowship within the past 5 years. And this is 80 cases over 2 years plus at least 16 cases which are designated complex. Next slide. The Focused Practice Designation does not replace, but rather expands upon board certification, identifying a surgeon's practice as more focused or with a higher level of expertise in thyroid and parathyroid surgery specifically. There's no direct relationship between the Focused Practice Designation and specialty boards. Next slide. And at least currently, the Focused Practice exam is not a requirement for credentialing, but those who take and pass the exam can apply for up to 50 Category 1 credits towards continuing medical education requirements. Next slide. I think that's the next section.
Great. So I'm going to review the eligibility requirements. So anybody who's going to apply has to have active certification in general surgery by the American Board of Surgery or certification by the American Board of Otolaryngology head and neck surgery. So that means you have to be in compliance with all maintenance of certification. So a good thing to check on before you're planning for this application. You also have to document participation in multidisciplinary care for patients with thyroid and parathyroid disease. So some examples of that include participation in multidisciplinary tumor boards, having joint clinics, potentially virtual tumor boards, other of the like. You then have to submit your case log demonstrating your significant experience with adult complex thyroid and parathyroid surgery, which we'll go into in more detail in the next slide. You have to have an unrestricted valid medical license in the United States or Canada with active surgical privileges in thyroid and parathyroid surgery. And you have to adhere to all of the ABS, ABOHNS codes of ethics and professionalism, meaning you have to be in good standing with your hospital and professional organizations. So you can't have any active sanctions against you. In terms of the case log requirements and volume threshold, we just went over this somewhat, but obviously your practice has to show an emphasis on complex thyroid and parathyroid surgery that varies somewhat depending on the track that you apply in. So these case logs for either the 3 years, 36-month, or 24-month case logs have to be submitted through the ABS or ABOHNS portal when you apply. And you have to have at least 20 parathyroidectomies and 20 thyroidectomies, so you can't be all thyroid or all parathyroid. Next slide. So what makes up a core case versus a complex case is listed here. So core cases include thyroidectomies, so lobectomies, total thyroidectomies, completion thyroidectomies, general parathyroidectomies, and then neck dissections for thyroid cancer, including both central neck dissection and lateral neck dissection. And what is considered complex is listed here. So substernal goiters, reoperative thyroid and parathyroid surgery, either prior thyroid parathyroid surgery or in a reoperative field. If there's prior external beam radiation therapy, prior recurrent laryngeal nerve paresis, any kind of visceral involvement from locally advanced thyroid cancer, so invasion of the larynx, trachea, or esophagus, or invasion of the nerve or vascular structures. No dissection in the parapharyngeal space, mediastinum or retropharyngeal space, And then any cases that involve the surgical management of medullary thyroid cancer, or actually any management of anaplastic thyroid cancer, is considered a complex case and something that can be listed in your case log for this. Next slide. So in terms of the application materials and deadlines, this is probably most relevant for all of you here who are thinking about applying this year. So applications are due on December 15th this year. So this is a great time now to start preparing your case logs and give notice to people who have to sign off. So I list them as references here, but it's really that the official for every hospital that you are submitting cases from your case log. You have to have an official for each of these institutions that will sign off and essentially attest to your case log before the deadline. So it's good to give notice to who these people will be at these institutions so that you make sure you're compliant. And of course, just counting your cases, make sure you have enough cases over the time period and know which category they're going to fall into for the complex specification. All of that's important to start getting ready now so that you don't leave this to the last minute. So the application components include the application form. You have to input the case log numbers, the names of these officials who will sign off. Also, you have to make sure that you're in good standing with your board. So right now is a good time as well to make sure that you don't have any other maintenance of certification to complete. When you submit your application before the December 15th deadline, that's when you will need to pay the $550 application fee. Then after you submit this, your application will be approved. When the application is approved, you'll be able to sign up for a testing site and date, which will be held between March 16th and 18th in 2026. It's when you do the second sign-up process that you'll have to pay the testing fee of $750. So those are the two fees that are involved in this process. And so during those 3 days, so March 16th, 17th, 18th, there'll be a number of testing sites local to you, and you'll be able to sign up and pick one of those dates. Important to try to sign up early because the testing times and availability, they will fill up because people are taking other tests there. So it's good once your application gets approved to log in and try and book the test. And then after you take the test, your results will be posted 4 to 8 weeks after the exam on the ABS or ABOHNS website. So here is a QR code where you can get all of the application information to apply.
Perfect. So I'll be covering the structure of the exam and what it actually assesses. The exam consists of 150 questions divided into 2 equal blocks of 75 questions. All of the questions are multi-choice, single best answer. Importantly, these are not simple recall questions. They're designed to test applied clinical knowledge of real-world scenarios that mirror what we face as thyroid and parathyroid surgeons every single day. Next. For now, the exam is administered at a Pearson VUE testing center. So yes, you'll likely be sitting alongside people taking the USMLEs or MBMEs and every other exam under the sun. It's a single-day exam with a total of 4.5 hours allotted for the exam, which is more than sufficient for 150 questions. Realistically, most people will finish between 2.5 hours. You'll sign in, begin session 1. You have 75 questions in 120 minutes. You get a break, and then complete a session 2 with another 75 questions in 120 minutes. And as Dr. Saib mentioned, the results will appear on the ABS portal in 48 weeks of the exam. The exam content spans the full breadth of endocrine surgery. The largest portion assesses thyroid diseases, followed by parathyroid diseases and surgical concepts. And you'll see a smaller, meaningful number of questions on anatomy, embryology, and physiology, because the exam aims to capture the foundational knowledge that guides safe and effective operative management decision-making that we make. This slide shows the detailed breakdown of the categories and subcategories. And as you can see, the scope is comprehensive. You may be asked about thyroid lymphoma. You can be asked about parathyroid cancer. You'll definitely encounter a question on secondary hyperparathyroidism, including cases driven by vitamin D deficiency. Next. What I appreciate most about this exam is how truly representative it is of a thyroid and parathyroid surgeon's practice. It doesn't stop at operative management. It stretches across the entire continuum of care. You'll see questions on epidemiology, healthcare disparities, diagnostic workup, multidisciplinary evaluation, intraoperative adjuncts, intraoperative decision-making, functional and cosmetic considerations, adjuvant and neoadjuvant therapies, post-operative surveillance, rehabilitation, and palliation. And in other words, it tests the same complexity we navigate with our patients every day. So with that, I'll turn you over to Dr. Sorensen.
Thanks. So my job is to talk about study strategies for this exam. And just to kind of start out in a lighthearted way, I spent 9 years as a clerkship director and used to like showing this visual abstract, which really someone was smart enough to publish that if you study more and use more different resources, you do better on the exam. So we all know that. We've all been taking standardized tests for decades, some of us. Next slide. So really, I think the punchline is to keep doing what you're doing. As I hope you've gathered from the talk so far, this really is representative of our practice. And so there shouldn't be concepts on here that you aren't, don't at least have passing familiarity with. All the sections here are from the website, screenshotted from the site on FPD. We've already been through all of the requirements, but again, in order to be eligible for this exam, you already know a lot. Go to the next slide. So there are a few QR codes on here of suggested reading. This is basically a Word document of various Sentinel papers. This was put together by the AHNS, and hopefully everybody's had time to grab that. And then these are QR codes which link to the AAES and the AHNS fellowship curricula, which are quite similar, as you might imagine. But basically a list of topics and good resources for primary sources. Next slide. And then, I think we kind of have all played the standardized test game enough to know that practice questions are part of it. And so board prep resources are really what will expose you to the similar style of questions. So for the ABS, CSAP is the module that we all use to study for boards, and there's an endocrine module that has 40 questions. And I've recently found out that there is an advanced endocrine module as well, which has another 20 or 30 questions in it. Those questions I thought were quite reflective of what we saw on the actual exam. And there's all the QR codes displayed on one slide.
I'd like to open it up. I'll go back to the slide previously, but to any questions that people want to put into the chat about the exam that are more detailed. A lot of what we presented was sort of at a higher level, but I do think what Dr. Sorensen said, keep doing what you're doing in terms of everyday practice. Oh, and I wanted to clarify, I believe, so the ABS deadline for American Board of Surgery is the 15th, but the ABOHNS deadline is December 1st with a late fee for the 5th. Is that correct, Joe?
That's correct. It's December 1st is the deadline for AAOHNS, but you can still do it by December 5th. The problem is there's a very high late fee, so you really want to do it by December 1st.
Dr. Pitt, do you all want to just come out of the slide view so everyone can see each other maybe? And I think if we could have 1 second, since we have a lot of time for discussion, I just wanted to introduce Dr. Michael Singer here on behalf of AOHNS and myself, Saray Parangi, on behalf of AAES, mostly to thank Dr. Pitt, Dr. Sharp, all the panelists who put together this session in record time, I would say, in the last 2 weeks. Because of the December 1 deadline for AOHNS and the December 15th deadline, we wanted to make sure to get this information to all of you. So you had a little bit of time to think about whether you do want to prepare and take this exam and at least sign up for it. We wanted to work together as the two societies who came together to advocate for this exam as well. So I also wanted to give a chance to Dr. Singer to make any comments.
Yeah, so thank you. So this was put together very quickly. I think for the American Head and Neck Society, I would say in record time, to be honest, which is pretty amazing. But I think that the session is just valuable for people to hear about the test. I think Susan and Joe maybe will get into the topic a little bit about why they think the test is valuable. And as someone who took the test last year, I'll just start out by saying that, I think once you say to surgeons that there's a test, everyone starts to get very nervous. But I think for probably everyone who's actually on this session, if you're doing thyroid and parathyroid surgery in any significant number and have some, robust experience, I can assure people that the test is I would say very fair. As you see with the pass rate, very, very passable. So I would not be discouraged or scared off simply because there's a test. And I do think, and I think Susan and Joe will get into this, there really is value with the FPD.
And I see that there's a question that came in the chat. I think each case that you do only counts as one case, so you can choose whether you want it to be a, one of the complex cases or, a standard case. But if you did a total with the central neck, you could only count it as the total or the central neck, but not both. And I thought it would be useful too if the panelists wanted to go around, and I can call on people, but just tell us kind of how they prepared for the exam. Dr. Noraldine, do you want to start? Because you're to my right on the screen.
Sure. For me, I brushed up a little bit on the management of anaplastic thyroid cancer. So I read the guidelines for the management of anaplastic thyroid cancer because there has been a change in the management of these patients, molecular testing playing a big role. So I wanted to brush up on that. And I think that's the only thing that I read about, maybe some management of medullary thyroid cancer as well, but that was it for me.
Liddy?
I'm in the group of people who have not taken it yet. So I am right, it's on my list. So, but I've talked with colleagues who have taken it, and I think that some of the guidance I was given was to brush up on guidelines as kind of a nice outline for what's important. I think the fellowship topics, I was in fellowship 10 years ago now, so brushing up on some of those topics is where I'm hoping to focus.
Great. Dr. Sorensen?
Yeah, it's similar. I did that CSAP module with those 40 questions, I think maybe the day before, and then brushed up on some systemic therapies.
Christine?
I focused a lot of my review on the CSAP questions, so both the standard endocrine questions and the advanced endocrine questions. I think that covered a lot, and then there were some areas where I wanted to do some research based on those questions. So I did targeted therapies and some of the hereditary conditions just to make sure I was up on those and the guidelines for those. And I did want to clarify that we all kind of laughed afterwards because at the end of the test, there was a survey to ask how many hours of studying you put in, and the categories were 0, 0 to 40, 40 to 400, greater than 400, I believe. So I think that probably the majority of people on this call do not need more than 400 hours of studying. I'd say almost all of us fell into the 0 to 4 hour, or probably 4 to 10 hour studying category.
Dr. Sharp, did you take it already?
Yes, I took it. I enjoyed it. I took the opportunity to kind of review guidelines, review papers. I teach residence fellows, and I think it's valuable to make sure that that you truly are up to date on all the guidelines for teaching. And I thought, as Dr. Singer said, it was a very fair test. People's practices could vary a little bit. There might be some people within our society that do a lot more parathyroid. Some might do more thyroid. Some might do more invasive thyroid. And so it gives an opportunity to kind of brush up on some of those areas that might not be as dominant, even in your endocrine practice.
Yeah, I felt like I had a grand plan of actually doing some studying, and in the end kind of ran out and just went in with the hope that I do enough of this every day that I would pass. And so, and I did. And I feel like it's a very fair exam, and they want to make sure that you're doing, I think the safe thing and the right thing. And so I think certain topics do tend to also, because they're very important, come up more than once too on the exam. There was a question I clarified in the chat. If you did a lobectomy and later a completion or a thyroid or recurrence, those would count as two separate cases in the case log.
It might be valuable to ask the panelists what Dr. Singer was saying is, like, why did you take the test? What was the motivation? Or, because there is a fee with it too. It's not for free. What drove everyone to do this test?
I'm happy to start. So I think it was a little bit just, this was a new test, and I think a way to distinguish yourself in your focus on thyroid parathyroid surgery. We talk a lot about how volume is important, experience is important, and it seemed like if there was a designation that could show that, that would be helpful for referring providers, provide confidence to patients. So I think and knowing that the AAES supported it, I think all of that just said, this is something that I know I'm going to do. I might as well be in the first group of people to do it. I don't think it has been, a huge change in my practice, but it's been something that I do think is helpful to distinguish yourself, as we talked about, from people who maybe do a few thyroids and parathyroids a year. It just felt like something that would be meaningful, provide confidence to referring providers, to patients. And if it was out there, it seems like something that I'd want to have.
I'll echo what Dr. Sieb mentioned. For me, as somebody who recently graduated fellowship and starting a practice and starting an endocrine surgery division, I felt that it was a way for me, for my patients, to kind of know my area of expertise, and as well for the referring physicians in the institute that I'm at, because they never had an endocrine surgeon, and at least showing that expertise. And this is the second time that we've done this webinar, and since the last time we did it, I've noticed a significant increase in the complexity of patients that I've been receiving, and they are referencing that's designation that they saw on my website, where I've been getting more of persistent recurrent primary hyperparathyroidism than I did before. And when I asked the patients, they do mention that they saw that this was an area of specialty, and they've been traveling an hour or two to come and see me for that.
I think for me, one of my motivators, was just because you've done this, you've do the fellowship, and so why not take the exam to kind of get the accreditation. But I think within our group, we have, there's several of us, my partners, I also wanted to make sure that I was kind of keeping up with what they were doing. So I think that was part of the presentation too.
I had the opportunity at my own institution. Sometimes I work with our spine surgeons, and it's very specialty agnostic, really. I can't tell who an orthopedic person is versus a neurosurgeon in my own institution. And it's a way of, a commonality that they share, focus on the spine. And I thought this was a language and a methodology to sort of make people who are interested in thyroid, parathyroid, to be a bit more specialty agnostic. And so, people would recognize, like, oh, this isn't an general endocrine surgeon or an otolaryngologist, but rather, this is someone who does thyroid, parathyroid, and I thought that could be a powerful mechanism.
I don't really have a lot to say beyond what everybody else has said, other than, for me, it was a little bit of lead by example as well. I chair the Endocrine Surgery Identity Committee for the AAES, and so I thought that this was, if this isn't endocrine surgery identity, I don't know what is. And also, similar to Dr. Nuraldeen, established the first endocrine surgery division at my institution, and so thought this was an important thing to be able to go to my departmental leadership and say that I had.
I'll chime in because I haven't taken it yet, but I think all of these reasons are the reasons it's on my list of to-dos. I think I don't see it changing my practice overnight, really. And so in my mind, it's kind of, I have a couple of years to get this done. I'm our residency program director, and that's just for the last 2.5 years, less than 2.5 years. So that took a little precedence and kind of how I've triaged my time. But I recognize the value, especially for kind of a more long-term vision, I guess.
Yeah, I noticed the question in the chat about kind of marketing the accreditation. I know Dr. Nuraldeen touched on this a little bit. We just haven't done any major marketing, but have, added it to our websites in terms of like the training and background on the, the basic kind of searchable. Have others on the panel done any specific marketing around the FPD?
I've not done any specific marketing. I just think it's helpful when you talk to patients. It used to be talking about being high volume, but now you can add in. I also have a focused practice designation in this, so factors in when I talk to patients. I've updated my profiles online, and I do think it is a helpful thing when if someone reaches out to you, maybe a new referring provider. It is information that I now provide to them. So again, a lot of this is maybe over time there may be more, and I agree it's not practice changing, but I think little bits it probably provides additional confidence and also sort of sets you aside maybe from other people who don't have this.
One thing that was interesting for me to learn is when Dr. Jo Beisky, who I think is the CEO of the American Board of Surgery, when she was talking about this exam, she mentioned that there are 6,000 patients daily that visit the American Board of Surgery to look up the certification of the physicians that they're seeing. And this is something that would be mentioned on the American Board of Surgery, that you have that designation. So I thought that was, we never knew that data, or that patients are looking up our certification, but maybe that helps as well.
I personally haven't used things for marketing at all. I'm in a bit of a setting that's a non-incentivized hospital in terms of what we do, but so I did for those other reasons that I've stated, though, certainly.
There's a question in the chat about periodically recertifying. My understanding is that there'll be recertification every 5 years is the current, but they have not shared any details about whether that's going to be back at a Pearson testing center, or will it, I don't know what the AHNS side of things are for their recertification, but if it'll be more similar to the American Board of Surgery, which is now a open book kind of take it over a couple weeks type of exam. I will say it was quite the throwback to be in a Pearson testing center, though, again, with all the like younger, I feel like people that were there and all of their notes and their pencils and their different things, but we'll see if we have to do that again.
Dr.
Yeah,
Kidd, how long did the test actually take you to finish? If each of you could comment on that, time-wise.
I think it was about 2.5 hours for myself to finish. And as I left the test, actually, the person there said he's never seen such a subspecialized test. They have a lot of different exams they give for all kinds of truck drivers, everything. He's never seen anything quite so specific.
Yeah, I think it similarly took me about 2 to 2.5 hours, somewhere in that range. Definitely not the whole, I think 4 hours that's allotted. And they do give you a little dry erase board and a pen if you want something like that.
Same for me. I think it was 2.5 hours.
Yep, and there are sections where, you know, it's similar to the normal standardized test where once you complete one section, you can't go back to it. But it was about 2.5 hours. I think I blocked out longer because I, you know, just wanted to, we didn't know what to expect. But that was about the same 2.5 hours.
From a scheduling perspective, and I think we did discuss this, but it was very convenient that I think there were 3 days over which you could take it and sign up. So like at least hopefully like one of those days is not an OR or clinic days. I think they offered it on a Monday, Tuesday, Wednesday last year. There's a question in the chat about the format for the case log, or if it's sort of the same as the ACS case log. I don't remember there being a specific format, but I feel like I just had I knew the different CPT codes, so I just had our people pull the codes that I knew were complex and not complex, and submitted those.
There's also a question on recertification. So it's, I think 5 years is my understanding, and then you'd have to recertify. So it's not indefinite, the certification.
If I'm remembering correctly, they also wanted 100% of your cases reported over that 3 years. Like you couldn't sort of get to 120 over 6 months and say you were good. They wanted to see like the entire span of the 3 years. I think I probably did underreport the complex cases because it was hard for me to know like 3 years ago who I did for medullary, but it was, you know, as someone who only does this, it was easy to get to that. It's not necessarily easy data to pull from your institution. You know, the substernal has its own CPT code, but some of the diagnosis specific things, just to echo everybody, if it's due in a couple weeks, get on that soon.
I would also try to advocate that you keep a log of your going forward, your patient number, the actual cases too, that there is an auditing process for this also. So they can audit the case log. So, you know, I actually wrote out all the patients and their clinic numbers and stuff for it.
I don't know if I know the question that Dr. Singer put in about everyone applying through the practice pathway. Do we know if that is true?
No, I think because about 20% of the people were through the training pathway, actually. So 80% were through the practice pathway, 20% through the training, and that ended up being for both societies, is my understanding. It's pretty evenly split from that the initial group that went through.
Dr. Pitt, I did want to mention that at the AAES last year, we did do a master's in thyroid and parathyroid surgery course, and a couple people have commented to me that they have looked at that course. It's actually available online. I'll put the link in, and it's available on our website. If you look on a computer, not on your phone, you'll see it easily, but I'll put the link in there too. It's about a 4-hour course, but it does cover a lot of the things that you all mentioned in terms of guidelines, medullary thyroid cancer, etc. So if anyone's interested in sort of rapid brush up after they sign up, of course, you're welcome to take a look at that as well. You don't have to be a member of AES to sign up and take it, and it's all a video format. So I'll put the link in case anyone's interested in that. It may prove helpful.
And you get a ton of CME, correct?
Maybe Lauren can answer that for me, but I do think you get some CME, but I'm not 100% sure of the exact number. But I did put it in the link, and we can 4 hours, so not a ton. But you do get a ton of CME for the exam, a huge amount. I forget the exact number, but it's extremely substantial.
50.
50, yeah.
It's a little cumbersome of a process, though, to get the credits. They don't automatically give them to you. There's like a form to fill out. And I don't know if that's the same on the ABOHNS side, if they also give credit for taking the exam.
No, there's not credit from taking the exam.
I think we're also open to hearing any concerns. Joe, I don't know if you could mute for a second. I don't know if people have any concerns about the exam or any worries that you want to bring up. I'm sure if you have a worry, other people have a worry. Like all of our life, when we have worries, it's usually shared by a lot of people. So feel free to ask questions or bring up any worries you have about the exam. No comments. That's a good sign.
I'm going to ask a question if okay. On the people who are on the panel, maybe you could talk a little bit. I know some of you may be like the only person in your division, but for others, maybe, say Susan, like, are you the only person in your group who took it? Did you all take it? And same question for others on the call.
A couple of my partners were on here. So 3 of us took it who were all eligible through the practice pathway. One of our partners is not eligible yet through the training pathway. And then one, we jokingly said grandfathered out and got very upset that we called him a grandfather. I mean, jokingly upset, not really, but yeah.
Yeah, I'll specify I am the most junior person in my practice. I was the only one in my group who took it. And I actually don't know for the head and neck surgery group whether any of them took it or not at my institution, but I do know within our group, I was the only one who did it. When I told everyone I had done it, they all said, yeah, we'll probably do that in the next few years. But I think maybe the more junior people felt more motivation to do it, but everybody expressed an interest and thought that it was something that would be worthwhile. They just, I think, didn't feel they had to do it in the first year.
For me, like, yes, I'm the only endocrine surgeon here in the Department of Surgery, but my head and neck colleagues, I have 2 of them who are head and neck trained, and a part of their practice encompasses endocrine surgery, and they were eligible to take the exam, and they took it. And it's not like a competition between me and them, but we actually brought all our forces together, where I felt that it empowered our, multidisciplinary team, our thyroid cancer center, where our message to the community is strengthened, that we have all these expertise that we can offer to patients. So, for me, I took it and they took it, and I think it's helped the institution with its mission.
Salam, I love that you brought that up, because I do think the biggest impact here will be to patients, right? For patients ultimately to be able to identify surgeons who are focused in this area, and make their life easier to find the right surgeon. Now, in the first decade of this exam, if I had to guess, I would say there'll still be a large group of people who don't take the exam or maybe aren't committed to it, no matter, how we encourage it. And so there'll still be some substantial difference, but over time, I think this exam will really, really help patients identify those people who really have taken the time to distinguish themselves by taking the exam, and often probably over time have also done a fellowship. So it'll be like a double substantiation down the road. And as you pointed out, patients do want to make sure their surgeons are certified. So, and I think it'll bring groups together like it is even here, right, in this conversation. None of this was happening before, so it's really opened that door.
That's really an excellent point, and that's kind of why I was getting to about being specialty agnostic, and you're hitting on it perfectly. From a hospital standpoint, a CEO does not want to deal with the inefficiencies of different specialties, fighting over cases, resources, but having a more unified front in taking care of this group of patients. I think this is a mechanism to kind of go in that direction.
I do want to acknowledge the cost of the exam and the fact that it will potentially be a recurring cost at 5 years. We don't know exactly the makeup of that cost. So I don't know if all of you who took the exam could say what role did that play, and what suggestions do you have around thinking around that? Because it is costly. We know obviously residents are coming out of fellowship with, fellows are coming out of fellowship with substantial medical loans, and it's a time when you're having to take multiple exams, relocating often for your family, a new job. How did you all think about it, and was there any help from your institutions in making sure there was reimbursement, for example, for the exam?
I pitched it as being a really exciting opportunity to be among the first people in the country to take it, and my department covered it.
Yep, I was in the same position. I sort of highlighted how this was an important thing, I thought, an important designation and something that showed we were committed to it, and my division covered the cost for both the application and the test.
My costs were also covered by the department.
My cost.
Go ahead.
Go ahead.
Mine were as well. It's almost like a society licensing almost kind of fee. It depends on how your hospital may view the terminology and how they reimburse for things. So ours were quite open to it.
Yeah, and for me, it was the same. It was a licensing exam, so they covered the cost, and it was not considered part of my CME.
I do think one thing that would be interesting, and I think is important to acknowledge, is I think that most, if not everyone who's on the panel tonight, is at a relatively large academic institution. And I don't know if anyone has, from speaking to colleagues, friends of theirs who are more kind of in community type practices. But I know that at least at the outset, there was a lot of interest kind of from quote, private practice physicians as well. So I don't know, have any of you like spoken to people who are more in like kind of community type practices and what their experiences or what their thoughts were about this?
I think you're right, Mike. Just talking with people around Chicago who have taken it, I think that was one motivator for some of my friends who have taken it, maybe at ancillary sites where they're not at like the mothership and they're trying to show their expertise in a setting where it's a little bit more challenging for them. And that was definitely a motivating factor.
Joe, I think you're muted.
Oh, I'm sorry. Michael, you did a wonderful job from our society in terms of the private practice section. And there was a lot of interest prior to that, but it would be nice maybe for us as a group also to go back and see how many people did follow through on that. But I don't have a lot of insight to it.
I will say, once you take it and pass, and in addition to getting a sort of diploma kind of thing for your wall, they also sent everyone, I think, a pin that you could wear on your white coat if that was something that would distinguish you as you walked around the hospital.
Dr. Pitt, someone mentioned it was a very big pin. Is that true? It's a very big physical pin? How big is it?
It fills your whole pocket. Like the only place I did put it on my white coat, but it's like the entire width of the pocket.
Very interesting.
Yeah, I was going to say it's like the size of a Post-it, but Salem's got his there.
There we go. Well, I want to thank all of you again, especially the panelists and Dr. Pitt and Dr. Sharp, who really put this session together in about 5 days after we asked them to put it together, and also to Lauren and Christina from the AHNS Society who put the Zoom together, and all of you for signing up and joining us. So big thank you really to all of you. I know this is recorded, so feel free to pass it on to your partners, your friends, other members who want to take a look. We'll send it. We'll put it on both websites so it's available. And the deadline is very close, so we knew that, and we tried our best to zip and zoom this to all of you.
Thank you all. I think you did a great job, and I can tell everyone who's on the call that both the AAES and the AHNS are very supportive of people taking this. I'm sure all the panelists, I'm speaking for them now, would be very happy to answer any questions anyone has on the test going forward. So thank you again, everyone.
Okay.
I think with that, we'll conclude and thank you all for your time on a Monday evening, and good luck on the test.
Thank you, everybody. Bye.